called the Mighty Heart Study. And the goal of the study was to compare two transitions of care interventions for patients with heart failure. Now, this is important because in the United States, patients with heart failure are the leading cause of hospitalization for Medicare beneficiaries. And this is very costly, both for patients in terms of their own well-being and their financial status, but it's also very costly for hospital systems because they often bear the burden of the financial costs on this, and they get penalties for patients to get readmitted within 30 days. And so because of that, hospitals are really motivated. And as a healthcare team, we're motivated to try and facilitate and improve this transitions period from when patients get discharged to home, from the hospital to home. And so this study compared two different interventions. One was a transitions of care coordinator, which is a pretty standard and traditional approach where a nurse calls patients 48 to 72 hours after discharge and follows up and discusses their post-discharge needs with them. Now, the other group also included that transitions of care call at 48 to 72 hours. But the second group was called mobile integrated health, and it included that nurse care coordinator in addition to community paramedics who would be dispatched by the nurse who was making those follow-up calls. And the community paramedic was trained in heart failure. They went through additional training with a heart failure specialist and would go into patients' homes, do med reconciliation, do a fall scan, do an assessment, and then facilitate a real-time telehealth visit with an emergency medicine doctor. And in that call, in that real video visit, they were able to address issues around new medications they might need. Occasionally they could give IV Lasix or some diuretics. There was a number of different things that they were able to take care of in that video visit. And then patients had access to this ongoing support with the nurse care coordinator, who once again could send out community paramedics as needed to those patients in that post-discharge period. So that was the study. We compared the two. We recruited over 2,000 patients in this pragmatic randomized controlled design, one-to-one to the two. We recruited patients across 2 health systems in New York City, which included 11 hospitals. And we recruited patients from January of 2021 to September of 2024. It's really important, right, for our research to be able to represent the patients who bear the highest burden of disease and who have the worst outcomes. And what we know from many of our trials is that they're not very representative of everybody who experiences a disease or a condition. And the groups that have been most underrepresented include women, and in the United States, underrepresented minorities, including Black and Hispanic and Asian patients, just to name a few. So in our study, in the Mighty Heart trial, we recruited 52% women, 47% Black, 27% Hispanic. We recruited patients in 5 different languages because we wanted that language to not be a barrier to recruitment. We also recruited patients across a wide spectrum in terms of we recruited patients with a high burden of social determinants of health or poor social determinants of health. Overall, in the sample, 40% of patients reported not having enough financial resources to make ends meet, and 75% had high school education or less. So these are just a few kind of basic metrics demonstrating that we were really reaching the patient populations that we most wanted to reach, who historically have not had the same level of access to digital tools and tools like telehealth. And so these are really the patient populations we wanted to get access to see if this intervention can work in those patient populations. So our 2 primary outcomes in this study, the first was health status, and the second was 30-day readmissions. For health status, we measured this using the Kansas City Cardiopathy Questionnaire, which is a disease-specific measure of health status for patients with heart failure, with higher scores indicating better health status. So overall, at baseline, they were the same between the 2 groups. And importantly, both interventions improved health status in a clinically meaningful way. So both groups had better health status at 30 days, but there was no difference between the health status between the MIH and TOCC groups until we looked at pre-specified interactions, and one of them was by age. What we found here was that in younger patients, the mobile integrated health intervention improved health status by 4.5 points, which is very close to the minimum threshold of clinical significance. And so this is important for us to kind of recognize. So the mobile integrated health group, both groups, both the older and the younger groups improved, but in the transitions of care coordinator, the older group improved, but the younger group did not. And there was, once again, those statistically significant differences between MIH and TOCC in that younger group. So why? Why would younger patients not do as well? So this is something we're still trying to really figure out. And so I think it's a little bit too early to say if we're ready to just target the intervention at specific groups like this. What we do think is probably going on here is that the patients in those younger groups, they were also at higher risk of poor social determinants of health. And so that's something that's going to be forthcoming in additional analyses so that we can kind of tease that out a little bit better. But I think that that's part of what's happening here is that that happened to be the group that had the biggest burden of poor social determinants of health. Now, for 30-day readmissions, this is obviously another really important outcome, a lot of costs wrapped into this outcome, and so there's a lot of interest here. We found that the hospitalization rate at 30 days was about 20%, which is basically what we anticipated it was going to be. Once again, there was no differences between the two groups, but there was interaction effects by sex. And this is where it was interesting. When we looked actually within the MIH group, between men and women who got access to MIH, women were 30% less likely to have a rehospitalization than men. Once again, why? What could possibly be driving that? Well, we're looking at this into a lot more detail in forthcoming analyses with our team. But what we think is happening here is that women in the sample were also more likely to live alone, be divorced or widowed than male counterparts. They also had less access to other additional caregiver support. And so we think that what's happening here is that the community paramedics, when they're supporting these older women who don't have a lot of other social support, they really can step in and meet the need to help prevent that hospitalization, maybe even through small interventions that they're doing in the home. That otherwise, if they hadn't had that, it would have tipped them over into needing to go back to the hospital. And the men in the sample were more likely to have caregiver support and not be living alone. So we think that that's probably part of what's driving some of those differences. But that is really important to be thinking about, right? And when we look at the broader vulnerabilities of patients as they're getting discharged from the hospital, we really have to take the bigger picture into context, and as we think about what's really going to help people not get readmitted and really be able to live well and recover well at home. So to get back to your main question, are we ready to specifically say this works only in this group or that group? Not yet. We really want to further improve the intervention. We're going to continue refining. And I think that, and also thinking about how we can, possibly be using community health workers in collaboration with the community paramedics to maybe even make it a stronger program. But once again, all of that's in the works as we kind of look towards future steps.